Hello everyone, my name is Dr Hester Lacey and I am the ClinicalKey Student Assessment Editor and the author of Crash Course Surgery 4th edition. This webinar is going to be going through high yield UKMLA topics relating to obstetrics and gynaecology in the form of 10 SBA questions. Let's get started. I'll just give a little bit of background to myself and Elsevier. So Elsevier own the ClinicalKey Student Question Bank, which is an online question bank with over 6,000 questions relating to basic medical science and clinical medicine. The Crash Course series is a 25-book series relating to different speciality topics. As you can see, the obstetrics and gynaecology version works alongside this webinar. I myself do editing for the ClinicalKey Student Question Banks of submissions, and I'm the sole author of Crash Course Surgery 4th edition. So here you can see all the conditions covered under the UKMLA syllabus for obstetrics and gynaecology. This webinar will go through 10 SBA questions relating to these conditions and high yield information relating to the correct answers and associated conditions. Let's get started with the first question. A 24-year-old woman has 6 hours of sudden severe right lower quadrant pain radiating to the right shoulder, profuse vaginal bleeding, nausea and lightheadedness. Her last menstrual period was 5 weeks ago. Her temperature is 37.8 degrees C, pulse 128 beats per minute, and blood pressure 95/61 millimeters of mercury. She has right lower quadrant pain, rigidity and guarding. Her cervix is closed with cervical motion tenderness and heavy vaginal bleeding. Investigations reveal a serum beta-HCG of over 2,800, and transvaginal ultrasound reveals an empty uterine cavity with a thickened endometrial lining and right 4 cm extra ovarian adnexal mass. Which is the most appropriate management? Is it A, expectant management, B, exploratory laparoscopy and salpingectomy, C, methotrexate, D, mifepristone and misoprostol, or E, salpingostomy? So I'll just give you about 30 seconds to read the question and think about the correct answer. And here we can see the correct answer is B, an exploratory laparoscopy and salpingectomy. In the next slides, we'll just discuss what makes that the correct answer. So the underlying diagnosis in this question is an ectopic pregnancy. The content covered in these slides, as you can see, comes from NICE CKS and NICE Guideline 126, which you can access online. All content in this webinar relates to NICE or the Royal College of Obstetrics and Gynaecology guidelines. So an ectopic pregnancy describes a fertilized ovum implanting and maturing outside the uterine cavity. The majority implant in the fallopian tube in the isthmus, but here in this diagram you can see several other possible locations of implantation. Risk factors for an ectopic pregnancy are anything leading to tubal damage such as pelvic inflammatory disease, older mothers, so age over 35 years, and a history of smoking. So the symptoms of an ectopic pregnancy most typically include abdominal or pelvic pain with amenorrhea or history of a missed period. Further symptoms may include vaginal bleeding with or without clots, shoulder tip pain, which relates to irritation of the phrenic nerve by free intraperitoneal fluid. There may be urinary or GI symptoms, change in bowel habit or dysuria. And in those with tubal rupture, this may present with acute abdominal pain and hemodynamic instability with dizziness, pre-syncope or syncope. Signs on examination of an ectopic pregnancy may include palpable abdominal tenderness or distension, cervical motion tenderness, peritonism, such as guarding and rigidity, tachycardia, and shock or collapse. NICE recommend that any mother with a positive pregnancy test and any of the above features are referred as an emergency to an early pregnancy assessment service. The diagnosis of an ectopic pregnancy is confirmed by a serum beta HCG, which confirms the pregnancy, and a transvaginal ultrasound, which you can see here in this image, which will demonstrate an empty uterus and a heterogeneous adnexal mass with no yolk sac or fetal pole, and the endometrium may be thickened and echogenic. So the management of an ectopic pregnancy relates to the presenting symptoms and signs. For those with features of rupture, so hemodynamic instability and severe pain and vaginal bleeding, you need to follow an A to E approach with appropriate resuscitation before definitive management. For patients with a beta HCG under 1000, an unruptured tubal ectopic pregnancy of under 35 millimeters with no visible heartbeat who agree to return for follow-up, management can include watchful waiting. Patients are advised to return if bleeding continues or pain develops, to repeat a urine pregnancy test after 7 to 10 days and return if it's positive, and advised that a negative pregnancy test means that the pregnancy has miscarried. Expectant management can be used in these cases as in patients with this low beta HCG level and a small tubal ectopic. It is highly likely that the pregnancy will naturally miscarry, hence medical or surgical treatment is not required. For patients with a beta HCG under 1500, an unruptured tubal pregnancy with no visible heartbeat and confirmed evidence of no intrauterine pregnancy who also agree to return for follow-up, medical management can include methotrexate. Methotrexate acts to inhibit folate-dependent DNA synthesis and triggers spontaneous abortion. It should only be used on the first visit when there is a definitive diagnosis of an ectopic pregnancy and a viable intrauterine pregnancy has been excluded due to the risks of methotrexate in inducing an abortion in this case. Surgical management with a salpingectomy is used for patients with pain, a beta HCG of over 5000, an adnexal mass over 35 millimeters, or any evidence of visible fetal heartbeat. Surgical management is preferred in these cases to definitively remove the ectopic pregnancy with no risk of the pregnancy then further developing and then rupturing, which can be life-threatening. A salpingectomy is used, which is removal of the entire fallopian tube. A salpingotomy can be considered for those with contralateral tube damage, for example, relating to pelvic inflammatory disease, where the pregnancy and that associated part of the tube is removed in isolation, which can preserve fertility. Moving on to the next question. A 28-year-old woman has 2 weeks of lower abdominal pain, nausea, dysuria, and foul yellow vaginal discharge. She has no regular sexual partner and had pain on recent sexual intercourse and a heavy, painful menstrual period 2 weeks ago. Her temperature is 37.8 degrees C. She has suprapubic tenderness, mucopurulent vaginal discharge, and cervical motion tenderness. Which is the most likely cause? A. Abnormal growth of endometrial tissue outside the uterus. B. Ascension of urogenital infection to the adnexal organs. C. Dysplasia of cervical cells. D. Extension of columnar epithelium to the ectocervix. Or E. Vaginal and cervical inflammation. So I'll just give you about 30 seconds to think about the correct answer. here we can see the correct answer is B, ascension of urogenital infection to the adnexal organs. So this question requires you to determine the underlying diagnosis and then remember the associated pathophysiology. We'll just go through this condition in the next few slides. So the underlying diagnosis in this case is pelvic inflammatory disease, which describes infection of the upper genital tract relating to spread of infection from the vagina and endocervix. The most common etiological organisms are chlamydia, gonorrhea, and Mycoplasma genitalium. Risk factors for pelvic inflammatory disease include patients aged under 25 years, unprotected sexual intercourse, multiple or new sexual partners, previous history of pelvic inflammatory disease and STIs, and recent instrumentation, typically with insertion of intrauterine devices. So clinical features of pelvic inflammatory disease include recent onset pelvic or lower abdominal pain, deep dyspareunia, so pain on sexual intercourse, secondary dysmenorrhea, abnormal vaginal bleeding, and mucopurulent vaginal discharge. Signs include lower abdominal adnexal tenderness, cervical motion tenderness, and a low-grade fever, features that we saw in this stem. So the management of pelvic inflammatory disease involves a pregnancy test to exclude underlying pregnancy, nucleic acid amplification testing for chlamydia and gonorrhea DNA, syphilis serology, and HIV testing. Before confirming the results of this, it is important to give empirical antibiotic therapy as soon as possible, involving IM ceftriaxone for gonorrhea and oral doxycycline for chlamydia infection. Abstinence is essential until a test of cure to avoid spreading STI organisms further, and this should also be managed with contact tracing and partner notification. Complications of pelvic inflammatory disease include adhesions, infertility, an increased risk of ectopic pregnancy, chronic pelvic pain, tubo-ovarian abscesses, and Fitzhugh-Curtis syndrome. Here we can see clinical images of some of the complications of pelvic inflammatory disease. On the left, you can see a tubo-ovarian abscess, which is an abscess that can develop in the fallopian tube or on the ovaries. In the centre, we see adhesions, which are abnormal, irregular bands of scar tissue that form between abdominal organs and the peritoneal lining, which can occur secondary to surgery, infection, trauma, or radiation, and have several associated complications, including bowel obstruction. And Fitzhugh-Curtis syndrome, which describes perihepatitis and is a chronic manifestation of PID, with inflammation of the liver capsule and adhesion formation and right upper quadrant pain. Moving on to the next question. A 42-year-old G1P0 at 34 weeks gestation has 2 days of severe headache, nausea, and blurred vision. She has type 2 diabetes mellitus managed with metformin and insulin. Both she and her baby were previously well. Her pulse is 133 beats per minute and blood pressure 156 over 94 millimeters of mercury. She has epigastric tenderness and bilateral pitting edema to the knees with brisk knee and ankle jerk reflexes. Investigations: urinalysis demonstrates plus protein and plus blood. Which is the most likely diagnosis? A. Acute fatty liver of pregnancy. B. Eclampsia. C. HELP syndrome. D. Obstetric cholestasis. Or E. Preeclampsia. So I'll just give you 30 seconds to think about the correct answer. And here you can see the correct answer is E, preeclampsia. Just going through some of the other options quickly. The acute fatty liver of pregnancy is a rare complication occurring in the third trimester, with rapid accumulation of fat within hepatocytes, which can cause an acute hepatitis syndrome. Symptoms include sudden onset malaise, nausea and vomiting, with jaundice, ascites, coagulopathy, polyuria, polydipsia, and abdominal pain. Its etiology is unknown. However, risk factors include multiple pregnancy, low BMI, and it often can occur with preeclampsia. It presents with elevated transaminases and bilirubin, reduced platelets, a raised white blood cell count, coagulopathy, and hyperglycemia. And management includes urgent delivery, typically by caesarean section, to prevent acute organ failure and death of both the mother and the fetus. However, after delivery, liver function typically normalizes completely. HELP syndrome describes a life-threatening variant of preeclampsia, resulting in systemic hemolysis, elevated liver enzymes, and low platelets, which form the acronym HELP. Again, the etiology is unclear, but it develops in those with existing preeclampsia. However, hypertension and proteinuria may be absent. Management is supportive, with resuscitation and management of any underlying coagulopathy, such as platelet transfusion, and the definitive management is delivery. There is a risk of both fetal and maternal mortality. Intrahepatic cholestasis of pregnancy, or obstetric cholestasis, results in reduced bile acid outflow, presenting with jaundice, pruritus, fatigue, dark urine, and pale stools. Again, the etiology is unclear, thought to be multifactorial, relating to genetic predisposition, exogenous factors, and increased sensitivity to estrogen during pregnancy. ALP is typically raised, normally raised in pregnancy, but if you see elevation in ALP alongside bilirubin, AST and ALT, and gamma GT, this suggests underlying cholestasis of pregnancy. The management involves ursodeoxycholic acid and supportive measures. It typically resolves completely after delivery, but complications can include preterm delivery, stillbirth, and a failure to pass meconium. Eclampsia is a severe variant of preeclampsia, which we're going to discuss in the next few slides. Preeclampsia describes the new onset of hypertension, so systolic blood pressure of over 140 millimeters of mercury and a diastolic blood pressure of over 90 millimeters of mercury after 20 weeks of pregnancy, with one of the following features: proteinuria, which is most common and most widely discussed, or renal insufficiency involving a creatinine over 90 micromoles per litre, liver involvement with elevated transaminases with or without right upper quadrant or epigastric abdominal pain, neurological complications such as eclampsia, altered mental status, blindness, stroke, clonus, severe headaches, or a persistent visual scotomata, hematological complications such as thrombocytopenia, so low platelet counts, DIC or evidence of hemolysis, and any uteroplacental dysfunction such as fetal growth restriction, abnormal umbilical artery Doppler waveform analysis, or stillbirth. It's important to be aware of these additional diagnostic criteria for preeclampsia, as most people generally discuss hypertension and proteinuria, but proteinuria can actually be absent in this condition. There are several risk factors for preeclampsia. Significant risk factors include previous or current hypertension, CKD, autoimmune disease including adrenal insufficiency, hypothyroidism, SLE, and diabetes itself is a significant independent risk factor. Moderate risk factors include first pregnancy, age over 40 years, BMI over 35, and multiple pregnancies. For patients with at least one high risk factor or several moderate risk factors, aspirin should be prescribed from 12 weeks gestation until birth. Diet and lifestyle measures to improve cardiovascular health should be recommended, and there should be regular monitoring and follow-up of both blood pressure and urine protein levels. For patients with preeclampsia with severe features or those progressing to eclampsia, active management of blood pressure is required. Features of severe preeclampsia include severe headache, any problems with the vision such as blurring or flashing before the eyes, severe pain just below the ribs or in the epigastric area, vomiting, and any sudden swelling or edema of the face, hands, or feet. These symptoms suggest imminent progression to preeclampsia, which presents with generalized tonic-clonic seizures. And notably, many seizures can occur intra or postpartum, so it's important to be aware of this risk. Management of preeclampsia depends on the severity of presenting features. However, typically inpatient management is required for those with severe features. This can involve intravenous labetalol to control the blood pressure. For patients who are stable but with some of the symptoms of preeclampsia, oral blood pressure reduction can be considered. Magnesium sulfate is given intravenously to reduce the risk of progression to eclamptic seizures. And for patients over 34 weeks who develop features of preeclampsia, expedited delivery is recommended, typically with caesarean section. For patients under 34 weeks gestation, the steps involve stabilization of the mother, administration of corticosteroids for fetal lung maturity, and expectant management until after 34 weeks. However, if there is any decline in fetal and maternal stability or development of eclamptic seizures, immediate delivery is required to reduce the risk of fetal and maternal death. Moving on to question 4. A 25-year-old woman has a routine smear test. She has no abnormal vaginal bleeding, discharge, or pelvic pain. Her last menstrual period was 2 weeks ago and was normal. She has a regular sexual partner, no previous sexually transmitted infections, and has the hormone-releasing intrauterine system. She has a smooth, pink, non-tender cervix. Investigations reveal HPV DNA negative for HPV 16 and 18. Which is the most appropriate management? Is it A, cervical biopsy, B, cervical cytology, C, colposcopy, D, repeat testing in 12 months, or E, return to routine recall? So I'll just give you about 30 seconds to think about the correct answer. So this question is assessing your understanding of the cervical screening programme in the UK. The correct answer is D, repeat testing in 12 months. So the cervical screening programme in the UK is set up to detect cases of cervical cancer. Cervical cancer is a cancer of the cervical epithelium, which typically arises from the cervical transformation zone. Most cases relate to a squamous cell carcinoma, however, adenocarcinomas can develop. There are several precancerous variants of cervical cancer before carcinoma develops. These are described cervical intraepithelial neoplasia with a grading from 1, 2 to 3. CIN1 describes low-grade dysplasia, which typically regress. CIN2 and 3 describe high-grade dysplasia. And cervical cancer describes extension of dysplasia beyond the basement membrane. Risk factors include high-risk HPV infections of strains 16 and 18, multiple sexual partners, an early age of first intercourse, unprotected sexual intercourse, and immunosuppression with a HIV infection, a significant risk factor, and smoking. This image is a representation of the progression of cervical intraepithelial neoplasia. So on the left, you can see all the normal cervical cells. CIN1 involves just a few dysplastic cells. CIN2, you can see there is a higher proportion of dysplastic cells involving a greater thickness of the cervical epithelium. And in CIN3, the majority of cells are affected. However, dysplasia does not extend beyond the basement membrane. CIN and cervical cancer are typically asymptomatic in early stages. When symptoms do develop, this is a sign of later stage disease and invasive cancer. Symptoms can include unexplained abnormal vaginal bleeding or discharge, pelvic pain or dyspareunia, postmenopausal bleeding or commonly postcoital bleeding, and any abnormal appearance of the cervix on examination with direct visualization of any lesions or ulcers or cervical epithelial abnormalities. Management of women with any of these features involves urgent referral for colposcopy. Surgical intervention is typically indicated relating to the extent of disease. So for local disease, you can consider large loop excision of the transformation zone or a trachelectomy with the removal of the entire cervix. And hysterectomy or pelvic extenteration is considered for later stage disease and metaplastic disease. Adjuvant platinum-based chemotherapy plus or minus radiotherapy may be offered depending on the clinical circumstance. So the cervical screening program was introduced in the UK to try and detect any asymptomatic early cervical changes that may progress to malignancy. Cervical screening is offered to all women or people with a cervix who are aged between 25 to 64 years. These people are sent their first invitation at age 24.5 to assure they can attend screening on their 25th birthday. For patients aged between 25 to 49 years, recall every 3 years is advised. And for patients aged between 50 and 64 years, recall every 5 years is offered. For patients aged over 60, they are only invited if recent screening was abnormal or they have had no tests in 65 years, since cervical cancer is much less common in this demographic. Cervical screening involves screening for high-risk HPV DNA, so strains 16 and 18, with cervical cytology performed only if high-risk HPV DNA is found, which demonstrates a change from the previous structure of the program, where both were performed automatically. Patients are invited for a colposcopy if evidence of abnormal cells is seen on cervical cytology, and during colposcopy, this involves magnified views of the cervix, and if there is any abnormal cells detected, biopsies can be performed. This flowchart demonstrates an overview of the cervical screening program. So we can see in this question, the investigation for HPV DNA was negative, hence return to routine recall was the correct answer. But on the left-hand side, you can see how the results of positive HPV DNA and cervical cytology are managed. Moving on to question 5. A 28-year-old G1P0 is entering the third stage of labour. Labour began spontaneously 28 hours ago, but she required intravenous oxytocin for a prolonged active first stage. During delivery of the placenta, she becomes lightheaded. Her pulse is 120 beats per minute, blood pressure 82/64 millimeters of mercury, and respiratory rate 32 breaths per minute. She has profuse, rapid vaginal bleeding and a soft, enlarged, boggy uterus. Which is the most likely cause? A. Postpartum endometritis. B. Retained products of conception. C. Uterine atony. D. Uterine inversion. Or E. Uterine rupture. So I'll just give you about 30 seconds to think about the correct answer. So in this question, this patient is having a postpartum hemorrhage. We can see that the correct answer is C, uterine atony. And we'll go through why in the following slides. So a postpartum hemorrhage describes loss of over 500 ml of blood from the genital tract. A primary postpartum hemorrhage is when this occurs within 24 hours of birth. and a secondary postpartum hemorrhage can occur between 24 hours and 12 weeks after birth. Postpartum hemorrhages are relatively common, affecting 5% of patients, and are the leading cause of maternal mortality worldwide. Postpartum hemorrhage are classified based on the extent of blood loss. So a minor postpartum hemorrhage is between 500 to 1,000 mils of blood loss. A major postpartum hemorrhage is with over 1 litre of blood loss, and a severe postpartum hemorrhage is with over 2 litres of blood loss. Postpartum hemorrhages typically relate to the 4 T's, so tone, which describes uterine atony, tissue, so any retained products of conception, trauma, so pelvic organ trauma such as uterine rupture or genital tract injury, which can occur intraoperatively, and thrombin, any inherited or acquired coagulopathies. Uterine atony is overwhelmingly the most common cause. Risk factors include uterine overdistension, so multiple pregnancies or macrosomia, prolonged delivery or prolonged oxytocin use, and any fetal, uterine, or placental anatomical abnormalities. The management of postpartum hemorrhage involves an A to E approach with resuscitation with warm fluids until there's blood products available. Typically, patients are resuscitated with up to 4 units of blood, followed by fresh frozen plasma and cryoprecipitate with the targets of fibrinogen and platelets outlined there. Oxytocin is typically used particularly in the management of uterine atony, and tranexamic acid may be given. Management then involves mechanical strategies such as manual compression or uterine packing. However, typically in major or severe postpartum hemorrhage, surgical intervention is required, which can involve intrauterine blue tamponade, B-Lynch compression sutures, and any uterine artery ligation. Hysterectomy is a last resort if the bleeding cannot be controlled. However, ARCOG recommend hysterectomy sooner rather than later if there is ongoing maternal and fetal instability. Complications of significant postpartum hemorrhage include both maternal and fetal death. This flowchart just demonstrates an overview of the approach to a postpartum hemorrhage involving resuscitation, then with the management of individual causes, with uterine atony the most common cause, following a stepwise approach with pharmacological, mechanical and surgical management, and the management of other etiologies of postpartum hemorrhage outlined below. Moving on to question 6. A 42-year-old G2P1 at 22 weeks gestation has 2 weeks of fatigue, thirst and urinary frequency. Both she and her baby were previously well. She has polycystic ovarian syndrome and high cholesterol. She is overweight with dry mucous membranes and reduced skin turgor. Investigations reveal a urine dipstick analysis of glucose 2+. Which test is most likely to confirm the diagnosis? A. Capillary blood glucose. B. C-peptide. C. HbA1c. D. An oral glucose tolerance test. Or E. Serum insulin. I'll just give you about 30 seconds to think about the correct answer. In this question, the underlying diagnosis is gestational diabetes. And the correct answer in that case is D, an oral glucose tolerance test. NICE describes diabetes in pregnancy or gestational diabetes as impaired glucose tolerance arising during pregnancy. It most commonly develops in the 2nd or 3rd trimester. Risk factors for gestational diabetes include a BMI above 30, a previous macrosomic baby weighing 4.5 kilograms or more, a previous history of gestational diabetes in a previous pregnancy, a family history of diabetes, any first-degree relatives with diabetes, and any ethnicities with a high prevalence of diabetes, such as Southeast Asian. Any women with these risk factors should be offered testing with the 72 grams 2-hour oral glucose tolerance test at 24 to 28 weeks to detect impaired glucose tolerance. The diagnosis of gestational diabetes is made in any women with a fasting plasma glucose above 5.6 millimoles per litre or a 2-hour plasma glucose of above 7.8 millimoles per litre. Management following diagnosis: for those with a fasting plasma glucose under 7 millimole per litre, diet and exercise are trialled in the first instance for 2-week period, with metformin then offered if blood glucose targets are not met after 2 weeks. For patients with a fasting plasma glucose above 7 millimoles per litre at diagnosis, diet and exercise is recommended and immediate insulin treatment with or without metformin should be offered. It is important to note that in any patients with evidence of complications such as macrosomia or polyhydramnios, consider immediate treatment with insulin with or without metformin and diet and exercise changes, even if fasting plasma glucose level is under 7 mol per litre. NICE recommends that the targets for blood glucose should be fasting plasma glucose of 5.3 millimoles per litre and 7.8 millimoles per litre 1 hour after meals, or 6.4 millimoles per litre 2 hours after meals. Aspirin should also be considered for prophylaxis of preeclampsia, and ultrasound monitoring of fetal growth and amniotic fluid volume is recommended every 4 weeks from 28 to 36 weeks. There are many complications of diabetes in pregnancy, both gestational diabetes and pre-existing diabetes. Maternal complications include preeclampsia, eclampsia and HELLP syndrome, an increased risk of development of gestational hypertension, and urinary tract infections. Fetal complications include polyhydramnia, so increased amniotic fluid volume around the fetus, which can increase the risk of umbilical cord prolapse and unstable fetal lie and breech delivery and the associated complications of these. Macrosomia, so a large fetus, can increase the risk of shoulder dystocia. Shoulder dystocia is an obstetric emergency in which the anterior shoulder of the fetus becomes impacted behind the maternal pubic symphysis during delivery. This can increase the risk of perinatal asphyxia and the need for a caesarean section. It can increase the risk of neonatal hypoglycemia. The pathology of this is where maternal hypoglycemia leads to fetal hypoglycemia, leading to hypertrophy and hyperfunctioning of the beta cells, fetal and neonatal hyperinsulinemia, which subsequently leads to transient hypoglycemia after birth when the maternal glucose supply stops. And diabetes in pregnancy also increases the risk of ARDS and transient tachypnea of the newborn. And this image is a representation of shoulder dystocia, and here we can see the anterior shoulder of the macrosomic baby impacted behind the maternal symphysis, arresting the progression of labour. Moving on to question 7. A 38-year-old G3-P2 at 32 weeks gestation has 2 days of painless light vaginal bleeding. Both she and her baby have been well throughout pregnancy thus far, and she takes only regular low-dose folic acid. Her pulse is 85 beats per minute and blood pressure 128 over 76 millimeters of mercury. The CTG shows a fetal heart rate of 142 beats per minute, with variability of 20 BPM and accelerations of 15 BPM. She has a soft, non-tender, gravid abdomen and minimal bright red blood per vagina. Which is the most likely diagnosis? A. Cervical ectropion. B. Placental abruption. C. Placenta accreta. D. Placenta previa. Or E. Vasa previa. So I'll just give you 30 seconds to think about the correct diagnosis. correct answer in this case is D, placenta previa, and we'll go through why in the following slides. I'd just like to highlight some of the features of this stem, including the CTG trace, which is reassuring as the fetal heart rate is between 110 and 160, the variability, which is reassuring between 5 and 25 beats per minute, and accelerations, which are a reassuring feature of a CTG trace. So the underlying diagnosis in this case is a placenta previa. A placenta previa describes a low-lying placenta partially or completely covering the cervical os. It typically presents with a painless antepartum hemorrhage, as seen in this case. Placenta previa is commonly identified at the 20-week anomaly scan and confirmed at a repeat scan at 32 weeks. The grade of the previa is dependent on its relationship to the cervical os and the severity of bleeding seen. You can see on the left-hand side of the image, there is a minor covering of the cervical os, but major previa is where there is complete covering of the cervical os. Risk factors for placenta previa include age over 35 years, multiparity, a short pregnancy interval, so a short gap between children, any previous uterine surgery, including a caesarean section, or a previous previa in a previous pregnancy. The symptoms of placenta previa include a painless, sudden antepartum hemorrhage, a soft, non-tender uterus, no evidence of fetal distress, as I highlighted with the reassuring CTG trace. These symptoms most commonly manifest in the third trimester and are typically self-limiting but may also recur. For comparison, I've included some features of placental abruption. This typically presents with a painful sudden antepartum hemorrhage, uterine tenderness with a hard, woody uterus, fetal distress, so a non-reassuring CTG trace with bradycardia, tachycardia, and late decelerations, shock or maternal hemodynamic instability. It is important to note that vaginal bleeding may be absent, as placental abruption may be concealed with a retroplacental hemorrhage. It is relatively common for placenta previa to resolve, so if detected at the 20-week scan, it may have resolved by the repeat scan at 32 weeks, resolved spontaneously. Management of previa, if persistent at 32 weeks, if between 34 and 35 plus 6 weeks of gestation, a single dose of corticosteroids is administered to promote fetal lung maturity, and delivery is scheduled between 36 and 37 weeks, as there is a risk of severe postpartum hemorrhage with spontaneous vaginal delivery. If patients are symptomatic, so they have vaginal bleeding, tocolysis is advised for at least 48 hours to facilitate steroid administration, with delivery at between 34 to 36 plus 6 weeks. However, if there are any features of maternal instability or severe blood loss, an emergency caesarean section is required. Moving on to question 8. A 38-year-old G2P1 at 35 weeks gestation has a spontaneous rupture of membranes. She has gestational diabetes managed with metformin, resulting in polyhydramnios with an unstable fetal lie. The CTG demonstrates a fetal heart rate of 95 beats per minute with recurrent late decelerations and variability of 3 beats per minute. She has a soft anterior cervix, 80% effaced and 7 centimeters dilated. There is a thick pulsating cord in the vagina. Which is the most appropriate next step? A. Emergency caesarean section. B. Elevation of the presenting part. C. Nifedipine. D. Replacement of the umbilical cord. Or E. Spontaneous vaginal delivery. I'll just give you about 30 seconds to think about the correct answer. So the underlying diagnosis in this case is an umbilical cord prolapse. We can determine this by the presence of a thick pulsating cord and an unreassuring CTG trace with fetal bradycardia, late decelerations and reduced variability. The most appropriate next step in this case is B, elevation of the presenting part. Umbilical cord prolapse describes descent of the umbilical cord alongside or in front of the fetal head. This results in compression of the cord between the head and the pelvic wall with maternal uterine contractions and life-threatening fetal hypoxia. Risk factors include any abnormal fetal lie, so any breech or transverse position, multiple pregnancy, polyhydramnios, which increases the risk of an unstable lie, and premature birth. Features suggestive of an umbilical cord prolapse is any abnormality in the CTG trace after the rupture of the fetal membranes and a palpable vaginal cord. In this case, we can see a CTG trace with deterioration of the fetal status, with development of fetal bradycardia and late decelerations, which is suggestive of fetal distress. The management of cord prolapse involves immediate maternal repositioning to alleviate compression on the cord, so advising the woman to get into the knee, chest position with manual elevation of the presenting part to reduce compression of the cord and fetal hypoxia. It is recommended to avoid handling the cord to avoid risking vasospasm, which can worsen hypoxia. But these manoeuvres should be followed by immediate caesarean section. Paired cord blood samples should be taken after delivery for pH and basic cess measurement, as this aids assessment of the extent of fetal hypoxia and the likelihood of subsequent neurological injury. Complications of cord prolapse include fetal asphyxia and death, and permanent neurological injury relating to hypoxic ischemic encephalopathy, which can proceed to the development of cerebral palsy. Question 9. A 32-year-old woman has 3 days of generalised joint pain, fever, rigors and malaise, after 10 days of foul vaginal discharge and pain when passing urine. She has systemic lupus erythematosus, managed with hydroxychloroquine. She has had unprotected sexual intercourse with 5 male partners in the last 3 months. Her temperature is 36.9 degrees C, pulse 102 beats per minute, and blood pressure 112 over 89 millimeters of mercury. She has tenderness, erythema, and reduced range of motion in the right ankle and left hip joints, with a diffuse vesicular rash on the trunk, lower abdominal pain, and mucopurulent foul vaginal discharge. Which complication has likely developed? Is it A, disseminated gonococcal infection, B, HIV seroconversion, C, reactive arthritis, D, secondary syphilis, or E, septic arthritis? I'll just give you about 30 seconds to think about the correct answer. This question is requiring you to determine the likely underlying cause and then the subsequent complication which has developed, which in this case is most likely to be A, disseminated gonococcal infection. So gonorrhea is a sexually transmitted infection caused by Neisseria gonorrhoeae bacteria. In uncomplicated infection, it typically affects the mucous membranes of the urethra, endocervix, rectum, pharynx, and conjunctiva. Symptoms typically develop between 2 to 8 days after exposure and can include mucopurulent or purulent urethral or vaginal discharge, dysuria, lower abdominal pain, and in women, intermenstrual bleeding. Risk factors for gonorrhea include unprotected sexual intercourse and multiple sexual partners. And here we can see a gram scan demonstrating Neisseria gonorrhoeae DNA. The management of gonorrhea includes nucleic acid amplification testing for both chlamydia and gonorrhea DNA, as they are commonly concurrent, contact tracing and partner notification, and antibiotics with IM ceftriaxone for gonorrhea and oral doxycycline if chlamydia is also present, and safe sex counselling to reduce the risk of further development of STIs. Complications of gonorrhea include pelvic inflammatory disease, subfertility and infertility, and the development of disseminated gonococcal infection. Disseminated gonococcal infection describes the systemic spread of Neisseria gonorrhea bacteria. There are several manifestations. As seen in this stem, we had an arthritis dermatitis syndrome with a polyarthritis, dermatitis, and tenosynovitis. It can present with a purulent asymmetric arthritis of multiple joints, and further features include development of conjunctivitis, meningitis, endocarditis, and pneumonia. There may or may not be concurrent genitourinary symptoms and constitutional features. There is an increased risk of development of disseminated gonococcal infection in immunocompromised patients, such as in this case, where there was a past medical history of SLA. The diagnosis involves blood cultures which will be positive for gonorrhea and nucleic acid amplification testing to confirm the underlying diagnosis, and management involves admission to hospital with intravenous ceftriaxone. Moving on to the final question. A 56-year-old woman has 7 weeks of intermittent vaginal bleeding and lower pelvic pain. She has 2 children born by spontaneous vaginal delivery and underwent menopause 4 years ago. She has hypertension and type 2 diabetes mellitus, managed with ramipril and metformin. She has conjunctival pallor with lower abdominal tenderness and mild abdominal distension. Which is the most likely diagnosis? Is it A, cervical cancer, B, endometrial cancer, C, endometriosis, D, pelvic inflammatory disease, or E, ovarian cancer? So I'll just give you about 30 seconds to think about the correct answer. The correct answer in this case is B, endometrial cancer. The key features in this stem are postmenopausal bleeding that lead us to the likely diagnosis. Endometrial cancer is a malignancy of the uterus wall. Risk factors for endometrial cancer include anything increasing estrogen exposure over the lifetime, including nulliparity, early menarche or late menopause, so an increased number of menstrual cycles, unopposed estrogen contraception or hormone replacement therapy, a past medical history of PCOS, hypertension or diabetes, and tamoxifen use in the treatment of breast cancer. NICE recommend that any woman over 55 years with postmenopausal bleeding should be referred down a suspected cancer pathway. Following referral, a transvaginal ultrasound is performed, and any women with an endometrial lining of above 4 mm, a biopsy with histology is then performed. The findings can include a endometrial hyperplasia with atypia of the cells, or an endometrial adenocarcinoma. In this case, we can see the transvaginal ultrasound showing a thickened, heterogeneous, cystic and vascular hyperkerk tissue filling the endometrial cavity as indicated on the arrows. Following confirmation of the diagnosis, management involves staging to determine any locoregional extension and myometrial invasion. Management typically involves a total hysterectomy with bilateral salpingo-oophorectomy, with or without sentinel lymph node biopsy, and pelvic or para-aortic lymph node resection if abnormalities are found. Uterine preservation can be considered for those with early stage disease, in those who are wishing to preserve fertility and complete their families if endometrial cancer develops prior to menopause. And that brings us to the end of this webinar on high yield UKMLA topics of obstetrics and gynaecology. We've covered ectopic pregnancy, PID, preeclampsia, cervical screening, PPH, diabetes in pregnancy, placenta previa and umbilical cord prolapse, gonorrhea and endometrial cancer. I hope this webinar was useful, a useful overview of the included topics, and we look forward to you joining us next time.